to do, which will actually enable you to actually understand what is the right things to do. Now, Sherry has done something different. He messes, man, he messes. Are you still there, Richard?
I am.
Right. So what, before I come over, Mr. Hines, Richard is going to be the only one who does a presentation for us this time. So before we come over, I was actually chatting to him about what we do in the UK. Now in the UK we can ask for a lot of different investigations and any investigation we want, as long as we can, you know, say that that investigation is warranted. In Pakistan you guys can actually ask for any investigation you want as long as the person's willing to pay. So what I'm asking him to do is today is to turn around, and his title is clinician or technician, and talk about how as an endoscopist you are perceived in your role, but also how you as an individual could sometimes request tests that are absolutely useless, but you ask for them anyway. So he wants to be controversial, so feel free to ask questions. Are you okay then, Richard?
Yeah, I think it's you that wants to be controversial, isn't it? I just support you in all of these things.
Yes.
Now, I've not seen Paul, obviously, for over a week. Has he been smiling a lot? Because he's just become a granddad for the first time. Were you aware of that?
I'm jumping up and down, man. Jumping up and down.
Congratulations, granddad. So we'll move on, and as Paul said, hopefully one of the things about this talk is to make you think about things, make you think about what you're doing, rather than necessarily just automatically doing the standard thing. And as he's already mentioned, healthcare worldwide, and in the UK in particular, has come under a lot of pressure, a lot of scrutiny from the financial side of things. And we both wonder if at times we are requesting a lot of up-to-date expensive tests unnecessarily, and hence trying to go back to being a clinician and think about what we're doing. Hence the title clinician or technician with regard to endoscopy. But there is a wider thing here about thought-provoking with regard to investigations. So tests and what to do with them. So just by way of an initial discussion point, we have a case of an 83-year-old man who was admitted as an emergency with acute sepsis, and was admitted to the gastroenterology ward for no particularly good reason apart from acute medical patients need to go to one particular area. He did have Enterococcus corona blood culture. An echo showed evidence of endocarditis. He did have a number of comorbidities, including being on warfarin. I think it was for AF, and his INR admission was 3.3. CT scan, because everybody over here seems to get a CT scan when they're admitted, showed a small amount of fluid in the pelvis with some changes in the ileum. And I stress here the ileum with an I. It was the iliac bone, not the small bowel. A colonoscopy was therefore requested to rule out colonic source of infection. Would you or wouldn't you do a colonoscopy in this situation?
So he's asking you the question, 83-year-old, with the history that he's given you, would you have asked for a colonoscopy in this individual? Be daring. Would you?
I'll put you out of your misery, shall I?
Please.
I didn't. A consultant surgeon had had a similar request 3 days earlier, and he didn't. Consultant gastroenterologist had documented in the notes that colonoscopy was not indicated. So we're all singing from the same hymn sheet, as it were, but we get these requests coming through, should you or shouldn't you do it? Now, other causes are being investigated. In this type of situation, essentially a normal CT scan will mean that a colonic cause is unlikely. if you're going to have a chronic cause of enterococcus in the bloodstream with this situation, you're probably going to have a perforation, sealed perforation, diverticular disease, something along those lines, which would show up on a CT scan. Colonoscopy is not without risk, especially in somebody 83 on warfarin. So an 83-year-old having full bowel preparation, not always a good idea. Warfarin, okay, you can do a diagnostic scope, but you certainly wouldn't want to be doing any biopsies or anything along those lines. But essentially, with a normal CT scan, you're not going to find a cause for the problem. So it's one of these things about, just because a request has been put in, you wouldn't necessarily as a technician do it. As a clinician, think about what we're doing. So just to talk about a few other tests, fecal calprotectin. I don't know how widely it's used over in Pakistan, but over the last couple of years, NICE have, or rather, NICE have said that it ought to be a first-line investigation in general practice before referring for cases of possible inflammatory bowel disease. Having said that, it is released in the intestines with inflammation. It's been said essentially to diagnose for UC and Crohn's, but is that correct or not? Many of us would say not, because fecal calprotectin is raised with any inflammation, can be raised if patients are taking non-steroidals, can be raised in colorectal cancer, cystic fibrosis, and there's some debate as to what actually is a normal level, because the normal range changes with age, and the level of fecal calprotectin can vary during the day. So all in all, it's probably not a very good test. And even the BSG recommendation is a bit vague about how it should be used. Moving on to another test that we often see, the C-reactive protein, one of the acute phase proteins. Locally, we've done 2 audits over the years of its use in the diagnosis of possible appendicitis. It's been shown to be of no diagnostic benefit. As far as acute presentation is concerned, the CRP is often normal because it lags behind clinical conditions, and therefore use as a diagnostic test, not very good, along with its non-specific nature. CEA and potentially other tumour markers, I use CEA here because of its use with colorectal cancer. Is it useful in diagnosis? Not really. Is it useful to detect recurrent disease? That's something that's been historically used on and off for the last 50 years in the UK. And every time somebody does a test, does an audit on it, it really doesn't seem to make any difference whatsoever, because you actually need quite a disease load if you're going to have an elevated CEA. But apart from anything else, not all colorectal cancers will express CEA. And as I've said, the fact it's been around for many years and it's still not established would indicate that it's actually not a very good test. Just to prove that I do like some tests, fecal elastase. I think it's great, mainly because GPs and trainees don't know what it is. And so by the time a patient gets to me, I take a history. A lot of patients get referred up with change of bowel habit, obviously, and pancreatic insufficiency is one of the rarer causes in our practice. So I do use it, but because I ask for the test, I know I'm going to get a good result. Going back to the clinician-technician business, if we go back to medical school, one of the things that was drummed into me was if you take a good history from the patient, you should be 90% towards a diagnosis. If you add to that clinical examination, you're 95% there. So from a clinical perspective, as a clinician, you should be a long way towards knowing what's wrong with your patient without any tests at all. But obviously, a number of tests are important just to prove the diagnosis, and in those cases where you're still not sure, they will actually clinch it for you totally. In essence, what we feel with tests is that they need to be used in the right context. Many of the tests that I've mentioned, DEA, CRP, calprotectin, their value is more in monitoring treatment rather than in diagnosis. And as far as treatment monitoring is concerned, they can be very, very useful. But as a diagnostic tool, many of them leave a lot to be desired. And so it's really using the tests that you have available to you, interpreting them in the clinical setting, we feel is the best way really of using many of these things. And at the end of the day, they're not free. They do cost. And in health services worldwide, as I've mentioned, that are short of cash, sometimes some of these things could be used in better ways.
Thank you very
Thank you very
much. Brilliant, Richard. So, anybody got any questions? Are these tests that you request, the test that is mentioned, CEA, CRP, are these tests that you've requested? Let's deal with the ones that is mentioned first, then we'll go to that. So, do you order CEAs, CRPs on a regular basis? No? So, surgeons may not, and physicians may do.
Yes, in our ward we are routinely doing these because to have an assessment of inflammation, we are doing these tests.
So you're saying it says an assessment for inflammation?
Actually, I just enter between your talk.
Okay.
I don't know the background.
No, no. What do you? What,
These are the markers for the inflammation.
and that's what Mr. Hines saying. Richard is saying. If the patient is, what he's saying is that the actual elevation lags behind the clinical picture for the patient. So when you actually do it, it actually gives you a false negative or a positive, or it's too late.
What I just want to highlight that as far as the assessment of the severity of the inflammatory colitis,
Yeah.
that is during the initial phase of the illness, whether CRP may not be high. It's always that
Are you talking about colitis or inflammation in
CRP, requesting the CRP in general.
in general.
Yeah.
So in any patient with the inflammatory disease anywhere, the CRP, especially during the early days of the illness, the CRP may not be so much high. So it's always the history.
Yeah, I think what I would like to clarify here is that if you are dealing with inflammatory bowel disease, CRP is a very poor predictor of inflammation.
Yes,
Which is what Richard has been saying.
Yes. So that is really not something which we should follow because it can always be misleading, and this is more so in ulcerative colitis. In Crohn's disease, it might be more representative because Crohn's disease is more of a systemic illness. Colitis, for some reason, it has been very difficult to find the proper inflammatory marker. People have used platelet counts, white cell counts, they all they all can change, but nothing gives you a precise degree of inflammation. White cell count can be misleading at times because if they are on steroids itself will elevate your white cell count. Serum albumin, they are not exactly markers of inflammation, they are surrogate markers of degree of disease, right? Okay. So that gives you a degree, idea of their protein losing enteropathy intensity. The important thing which we fortunately, more recently, we have been blessed with an investigation which is called fecal calprotectin. Now that is more representative of inflammatory activity, but again it is not precise because any other... because any other inflammatory condition like
my friend.
Any inflammatory condition like infection or cancer can also cause aggravation. But it's a very good marker.
So we've had a power cut. What Bakar, who's a consultant who used to be in Bangor but now a very eminent gastroenterologist in Manchester, of many years experience equivalent to your own, he's actually completely concurring with you with regards CRP, and he's also suggesting that fecal elastase is a quality test as well, and calprotectin as well. So he's actually saying that test is actually of a quality indicator for himself. I know what you were saying with regards FCP can actually show inflammation for many other reasons, including NSAIDs and other causes for in the bowel. But I'm going to ask him now, what do you think of fecal elastase, Vakar?
Fecal elastase in investigation of diarrhea is an important tool because to exclude any pancreatic exocrine insufficiency. Because we do pick up the odd case of chronic pancreatitis by doing fecal elastase, especially in case of obscure diarrhea. So yes, it is important. I normally send in such cases stool samples both for fecal elastase and calprotectin. But if it's a known case of colitis, then obviously you are using it more for prognostic activities as well. But with the proviso that it can go up with other conditions like NSAID-induced inflammation, cancer, infected diarrheas, and diverticulitis as well.
I think what Rich is highlighting is that the younger consultants coming through will order all these tests. They'll order a gamut of tests and deal and look at the results when they come and won't know what to do at the results. The more mature consultant will actually look and ask for the test that they think is actually going to support what he's shown by his data. His data is saying a good clinical examination, a good history, and the 5% is from your test. So your test is only there to support what your process is monitoring, and that's what the test is. So what he's actually trying to get you to do is think about the appropriate test at the appropriate time for that patient. And there's lots of tests that we ask for that are completely useless, but we ask for them. And they have...
Sorry to cut in, Paul. I can't really hear the discussion from the room because it's not being picked up on the microphone. But essentially, one of the things that we're sort of looking at is using the tests in the right clinical context. And one of the other things that we get quite a lot is that we'll have a GP refer a patient in because they've got a CEA of 3.6 or a fecal calprotectin of 249, and what do they do with it? And you then end up having to do a lot of expensive tests because of that initial screen that a GP's done that is really not particularly helpful. And you're chasing numbers rather than treating patients is one of the aspects that we seem to be heading towards more.
I agree with you. We have had one query, Richard. What do you think about CT colonoscopy? Before I actually put you back to the audience, I'm going to say to you in the UK, CT colonoscopy, when done, is a standard diagnostic tool to say if a patient's got cancer or not. So the question from the same person is that CT colography in someone who's old and a seriously septic patient?
Again, as I've already mentioned, in that sort of situation, if you're looking for serious sepsis, then a standard contrast CT and not necessarily doing a CT colon, because with a CT colon, you obviously got to give bowel prep for a couple of days beforehand, although not the full mechanical bowel prep. But you want an immediate answer, and if there's something significant in the colon, you will pick it up on a standard contrast CT. As far as the CT colography is concerned in our standard practice, we would use it in patients who we want to have a colonic diagnosis but feel that they wouldn't manage mechanical bowel preparations. So the gold standard essentially is still colonoscopy across the board, but in certain individuals, particularly the elderly, we would consider CT colography because the bowel preparation is gentler. And in somebody who is really fairly elderly and frail, but we want to know if there's anything gross within the colon, then again, just standard CT. But CT colography will show, smallish polyps. It is a pretty accurate procedure, but obviously carries a radiation risk, which in younger people and for screening surveillance, you wouldn't necessarily want to go down that route. So we do use it, but only in a small proportion of patients.
Okay. Have we got any more questions? Has it made you think about the test that you request? So has what Richard has been saying, has it made you think about why you request a test, or what the purpose of the test is? The big reason that he's actually done this is that in the UK we do a lot of tests that are completely inappropriate. And all they do is just hinder and cause issues. And we get blinded and we actually then follow a wrong channel. And so what we need to do is actually understand where we're going with a lot of this. In the UK, how consultants are being developed now, they're cutting short the teaching and the training and the development opportunities that a consultant will spend, a junior will spend in becoming a consultant. A consultant, in my opinion, is there to be consulted. He's there, he should actually, if he doesn't know the answer, he should know where you can get the answer. A consultant should be able to support and not deride, but guide you and support you. But also, a consultant should be able to turn to you and say when you're making the wrong decision and tell you, whether it upsets you or not, that your decision has been rubbish. And sometimes that is a very difficult one for us to do and handle. That you think your clinical acumen has allowed you to actually suggest this is the right thing to do, but it's not necessarily the correct thing to do. So there's a big difference between being right, because it does have does contribute something, but being correct is the major difference. Now Richard's very busy. I'm going to ask if we got any more questions of him. We've got a hell of a power cut here, my friend.
Right. That explains why we're only on verbals and not video.
Absolutely. So, I think that the presentation that you've had, even though short and succinct, has been quite thought-provoking. Even if the tests that you order and request haven't been mentioned, there are a lot more tests that are out there. What was that, man? Was that the dog?
No, it's not my end.
Oh, it's my end then.
But
So-
yeah, I mean, as you say, Paul, I mean, the few examples that we've given here are just that. They're just a few examples. And it's really hopefully to get people thinking rather than actually doing things by numbers, as it were.
Yeah. The big thing that I can't stand is when people have a diagnosis. So I see a patient today, they've got pancreatitis. The patient, 2 weeks' time, they request another colonoscopy because they say the patient's failing to respond. The treatment's not correct. How about that? And that's the big one. That's very difficult in the UK. They'll find other reasons to say, oh, it could be infective, could be this, could be that. No, your treatment regime is not correct. Go back to the drawing board. And what the title was, clinician or technician. As an endoscopist, you're doing a test. As an endoscopist, you can either get on the bus or stay off the bus. So in other words, what you see, how do you manage it, what do you say, what are the tests that you organise based on the evidence that's in front of you. This young man said earlier, because the patient had the symptoms of melena, shouldn't that patient have had a gastroscopy? Perfectly correct. So that's what's been ordered. But it was already ordered. But the most important thing is to organise, as an endoscopist, the test that is right afterwards. If you don't, and you send it back to the clinician concerned, or, as working in with this institute, goes back to the ward with no recommendations, the problem comes is, what do they do with the patient? You're an endoscopist, you're an expert in that area, so you should actually know what to do with what's in front of you. Otherwise, you shouldn't be doing it. Simple as that. Richard, I thank you very much for your time, my friend.
You're very welcome, Paul. You're very welcome, everyone.
I'll
See you next time.
Next Tuesday, my friend. See you soon.
Bye.
Bye-bye.
I think this is a very important issue that Richard has raised, because mentioned initially also yesterday that you only do a test that is going to change your management. If that test is not going to change your management, there's no point in doing it. Because like the scenario is depicted is very typical. A GP would send me a patient who they have done random tests like CEA or CA19-9 and that is marginally raised. Now you don't know what the hell to do with that patient. Because the patient is well, there's nothing wrong with him, but he's got an abnormal test. And you do not go around chasing abnormal tests. You treat and investigate a patient, not a test. So that is the important thing.
You hear what Bakar was saying?
Yeah.
You've ordered the test, and it's like what I've said earlier. You've ordered the test, and your reaction is the result of the test. Was it the right test to ask for?
Exactly. I mean, there have been loads of examples I can quote you. Like, you know, people come with marginally raised cancer, oh, let's do his calcitonin level, let's do his, parathyroid level. And you end up with some of these tests are not, they are very specialized tests. Their, reference range is quite wide at times. And the laboratories also differ in them. And you may get marginally raised tests and you end up in a sequence of events which is totally pointless. At the end of the day, you'll find out after a good few weeks, few months later that you've done over 20, 30 different investigations, put the patient through even the basic procedure, and the end result was basically nothing. So always be very choosy in what you investigate. The other thing is picking up the right investigation, just like Richard mentioned about CT scans. There are, when you do request a CT scan, you should have exactly in your mind what you want to do. You don't do just blanket CT scans of chest, abdomen, pelvis. Yes, you do them in staging cancers, right? But if you want to look for a pancreatic lesion, then you ask for a triple phase pancreatic protocol abdominal CT scan, because the whole sequence is different. They use thin slicing a spiral CT and use contrast with non-contrast, portal phase, arterial phase, all triple phase CT. And the same applies to liver lesions. Now, if you are suspecting a liver lesion or an ultrasound scan has picked up a liver lesion, then you would ask the ideal test to ask for is an MRI scan, contrast enhanced, not the MRCP, because that gives you a better tip. So everything you have to be, now, like, we are suspecting sepsis, yeah, the investigation of choice is a CT scan of the abdomen, or chest, abdomen, pelvis at that way, because you might pick up an abscess somewhere, right? And you can, most of the abdominal CT scans are now so sensitive that they will pick up a gross colonic lesion as well. CT colonoscopy is, again, a test which you should choose very carefully, because even if you do it in a 90-year-old granny and you do a CT colonoscopy and it picks up a cancer, what are you going to do about it? Yes, if she's very fit and can undergo surgery, then by all means do everything, colonoscopy and CT colonoscopy and colonic resection. But if she's crumbling, bed-bound, what's the point, right? So always be very clear in your mind, because don't forget, CT scan means lots of radiation. You might do CT scan now, but 10 years later you might have the effects of cancer.
Can you see how the requesting of tests causes a lot of difference in opinion? Especially with senior guys, because me myself, I don't order a lot of tests. I don't. I'm very specific about what I want to do. I don't know.
But and back in the city